everyone. My name is Michael Ruiz. I'm the current interventional echocardiography fellow at St. Michael's Hospital, and it's my pleasure to present to you this presentation as part of our Echo Bootcamp series. So this lecture we prepared to be part of the Echo Bootcamp that we started in 2024 at St. Michael's Hospital for the University of Toronto. To help make the bootcamp run more efficiently, we've now recorded this lecture and included it on the SMH Echo YouTube channel to be available for our residents, but also for anyone else who may be interested in running their own Echo bootcamp at their own site. If you're interested in preparing an Echo Bootcamp, I'm very happy to collaborate and share some of the ideas we've had from the University of Toronto, and my email is included on this presentation slide. The Echo Bootcamp is entitled Echo Bootcamp Core Concepts Lecture, Physics, Knobology, and Beyond 2D. And this lecture is really meant to be a companion to a lecture that was prepared by my colleague, Dr. Claudia Frankfurter. She created a lecture that's available on our YouTube channel on the comprehensive echocardiography guidelines from the ASE. So for those attending the bootcamp, please watch that lecture in addition to this lecture, and both are great starts for anyone who is new to echo. This is a sample of what our echocardiography bootcamp will be like, and potentially provides a guideline for anyone who's interested in running their own echo bootcamp. So the goals of our Echo Bootcamp are really to review concepts around echocardiography, and we're trying to keep it simple and we're trying to keep it focused. And really what I want you to grasp is how and why we do things. And we'll keep things in simple terms that you will eventually build up as you go through cardiology training. There's only so much we can accomplish within an Echo Bootcamp, so we have to be realistic in what our goals are. We're going to talk about this concept of knobology, and so this will give you orientation into the various knobs and buttons associated with the Echo machines and how they're going to make your images better. You're going to practice that. In addition, one of the key goals of our Echo Bootcamp, and what we try to optimize this year, is in optimizing the scanning time with a standardized patient. And so with this, you'll be scanning a standardized patient with a sonographer. You'll learn how to obtain the basic views, make adjustments, and acquire images. And this will hopefully help ease the transition to your own echo rotations as you begin your cardiology training. So we need to keep expectations realistic, as I mentioned. You're not going to be expected to know how to do a full echo after this single session. What I would like you to understand is the basic windows, what we can see in these windows, and then you will build on that over time. You will not be expected to answer questions with an echo on call after this session. Again, echo requires exposure, repetition for both image acquisition and interpretation. It's going to take months of practice of scanning and reading to be competent with echo. We're going to show you some pathology as part of the boot camp, but you will not be equipped on call to do echoes after this single session. So we have to be realistic in that domain. You will not be expected to produce perfectly optimized images after this session. Again, that would not be realistic, but we're going to teach you how to get the basic windows, how to move the probe, and how you can use the probe adjustments and adjustment of the various knobs to optimize your images. And you're not going to be expected to how to do measurements or interpret images after this session. Again, this is going to take time in terms of scanning and interpreting hundreds of echoes along your training. We're going to provide, when you're not scanning, some introduction into measurements, but you're going to build on that over time. So some principles of echocardiography. The standard views of echocardiography were reviewed in Dr. Frankfurter's lecture available on the SMH Echo YouTube channel, so I highly recommend that you watch that lecture as well. In addition, in this session, we're going to focus and review further principles of echo in simple terms to help you understand how and why we acquire images and optimize the images in echocardiography. So one of the most important first steps is to prepare yourself for success. And that's really in how you prepare the patient. So the first thing to do will be to ensure that you have the correct study listed so that the images are saved under the right patient. The study is loaded. We always include a baseline blood pressure, as this gives us an idea of the patient's loading conditions for the study. And then inputting the height and weight are very important for indexing values. So all of these are important as you set up before you even start taking images. Positioning the patient is very important as well. The exam will generally start with will generally start with the parasternal long axis view, and therefore the patient's positioned in the left lateral decubitus position, as this brings the heart closer to the chest wall and allows for better image optimization. The left arm underneath the head will help to open up the rib spaces, and that can also help to optimize your images. Draping is very important as well. Towels or gowns can be used to cover the chest, and only the areas that are being examined should be exposed. Lastly, ECG leads are also an important part of the study. So it's important to know how to set up the ECG leads. The reason why they're important is that the images that you acquire will be gated to the ECG so that they loop properly. And the ECG is very important to help us know the phase of the cardiac cycle, which is helpful for understanding pathology and taking specific measurements. One of the mnemonics that I learned was white over right, smoke over fire. And so this, is a helpful but you can remind yourself that the RA or the white lead goes over the right arm, the black lead goes over the left arm, and then the left leg or the red lead goes over the left side inferiorly. You're going to pick the number of cycles. So if the patient's in sinus rhythm, generally 2 beats is adequate. But if they're in an irregular heart rhythm like atrial fibrillation, then 3 beats would be preferred. And you're going to pick which lead works best. They generally default on lead 2, but sometimes lead 3 looks better. So that's another way to set yourself up for success. In terms of image acquisition and optimization, before we get into where and how to place the probe, we're going to discuss some basic physics in terms of how your echo machine will help you optimize the image. So the echo probe is a phased array probe. It's used for 2D echo image acquisition, and sound waves are emitted by the probe, sent to tissue, they bounce off tissue, and then go back to the probe, and an image is generated. And as you can see on the image on the right side, as sound waves are being emitted from the echo probe, again, some will be dissipated through the tissue, some will penetrate one layer, but then will bounce back, some will penetrate multiple layers and then bounce back. And it's through this constant signaling and the sending back and forth between the probe and the reflection from the tissue that will then allow, through integration, the creation of a 2D image. So sound waves need a medium to go through, and note that air will scatter sound waves and that images can't be acquired. So a situation where this might occur is in a patient who has suffered a pneumothorax and has air within the pleural space that then will not allow you to acquire images because air does not transmit sound waves very well. And so I always say rib spaces are your friends. You're not going to acquire good images over the bone itself, but in between the rib spaces and in between the bones is how you will see the heart. And so we use this term called acoustic windows, which are the typical points on the patient's chest where we are able to acquire the echo images. The heart is in contact at the parasternal area with the chest, and that allows us to visualize it quite well, not really looking through lung tissue. At the apex is also an area of contact which allows us, and that's shown by number 2 on the right-sided image. The subcostal view is also an area where we can see the heart through the abdominal cavity, perhaps looking through the liver, and then the suprasternal view, number 4 on the acoustic windows diagram on the right, is also an area where we can visualize cardiac structures. So when we do echo, it's really to answer, a clinical question. Is the LV function normal or abnormal? And if it's abnormal, how abnormal is it? So to do this, we need well-optimized images, which is an interplay of lining up the echo beam to the cardiac structure in question, in addition to optimizing the characteristics of the image itself. And this may include features like size, brightness, frame rate. And we'll show you how to do that throughout this presentation, and at least introduce those concepts and then build on that during the scanning time with the sonographer and standardized patient. So we're going to talk about probe movements. As you scan patients today and going forward, the sonographers that help to train you will be using different terminology. And so we're going to introduce the various terminology through the next few slides. So tilting is a maneuver by which the transducer becomes tilted. Sometimes fanning is also a term that is used, and so by tilting the probe, we can open up various structures. So, for example, in image number 3, this shows the apical four-chamber view. By tilting the probe up a little bit, we get image 2, which is the five-chamber view. You open up the LVOT and see the aorta, and so that's an example of tilting and how that helps you view different cardiac structures. Rotation is also another movement that's intuitive. This can be rotating left or rotating right, basically rotating the probe along its axis from a clockwise to a counterclockwise manner. And this can be, for example, on the image on the left with the probe indicator dot pointing towards the patient's right shoulder. By rotating it clockwise towards the left shoulder, you're able to go from a long axis to a parasternal short axis view. Sliding is moving the probe essentially up and down the patient's chest. So that's an example of sliding, basically moving in between the different rib spaces, for example, or moving up and down within a rib space. And then rocking is another maneuver. It's sort of like tilting, but along the opposite axis. Instead of tilting or fanning, you're rocking the probe from one side to the other, away from the orientation index marker or toward the orientation index marker, and that focuses the images on different parts of the cardiac structure as shown here. And we'll practice these maneuvers as we go through and scan the patients, but I wanted some introduction to the various movements. Angulation is also another way of basically bringing one structure into one viewing and see how it's angulated towards the tricuspid valve in the short axis on the image on the left. And then by sliding the probe and rocking slightly, you angulate the probe into a bit of a different angle. And starting to the left and angulating, you angulate towards the pulmonary artery and pulmonic valve. We also bring up this concept of on-axis versus off-axis, and you're going to see this come up again and again as you scan and interpret images. And so axis refers to if the image is lined up properly with the view you're trying to obtain. And so, for example, one of the ways we look at this in the in the apical four-chamber view is looking at the images on the right that are on axis with the blue arrow. You see sort of a straight line down the interventricular septum and interatrial septum. And really you see everything lined up well on axis. You can see on the images towards the left side of the screen, the images is tilted slightly. The interventricular septum and the interatrial septum are not quite straight up and down. The image is a little bit off axis. The reason why this is important is that this can distort the imaging. It can potentially present things in slightly misleading ways, and so we try our best to have things on axis as best as possible, and it's not always possible for every patient, but we try to have things on axis as best possible to ensure that we're giving accurate data. And in this case, taking some time with the sonographers and practicing your micro movements will be very important. Foreshortening is also another concept, and this is basically when the ultrasound beam does not cut through the true apex of the left ventricle, which leads to a geometric distortion of the left ventricle. It makes it look more blobby or rounded instead of the usual bullet shape, and some figures are shown on the right side of the screen to show examples of foreshortening. The reason the reason this can happen is that we've just not lined up well at the apex, and the consequence of this is that the LV looks shorter, the apex looks thicker, the function can often be overestimated, and so breath holding can often be helpful here to move the heart into a bit of a lower position, or perhaps maybe doing an exhale to raise the heart up a little bit higher to optimize the image so that we're no longer foreshortened. So this is an example, quite a dramatic example of a patient where they are foreshortened on the left side of the screen. And on the right side of the screen, the apex is opened up well, and you can see that there's a defect in echogenic mass, likely an LV thrombus associated with the akinesis of the apex that we would have missed if the image wasn't optimized properly. So paying attention to this is important as you scan patients, and that'll be your goal eventually as you scan more and more patients to try to minimize foreshortening and try to get your images on axis. And again, don't worry about getting these things perfect during today's session. You're going to build on this over time. So knobology, we're going to go through the various knobs and buttons that are common on an echocardiography console. We're going to review in big picture what these knobs and buttons do, and we're going to build on that throughout the rest of the boot camp. So in general, the dominant hand is used to hold the probe and generate images. Your non-dominant hand will be pressing buttons as you scan. Some people, especially sonographers who scan for a living, will often train both hands to be able to scan and hold the probe. And it's a good way from a mechanical point of view to help preserve strength and reduce injury. It's up to you to decide how you would like to scan, but most people will start with scanning with their dominant hand just from ease of the mechanics. Knobology refers to how we use the different knobs on the console to optimize your image, and we're going to review the different knobs in simple terms for what you need to know to get your images as great as possible. So this is an example of a console from a GE machine. There are lots of buttons and knobs on here, and we've highlighted a few key ones for you, and we're going to go through what each of them does over the next several slides. So the first one we're going to look at is depth, and this is quite intuitive. It makes your image more deep or more shallow. Essentially, what you're telling the ultrasound probe in the machine to do is to send sound waves deeper. They reflect deeper, and then they will take longer to come back up to the probe. So what this does is this is going to drop your spatial resolution because we're now going to have to rely on sound waves going deeper. We're going to lose resolution than if we had made a much more shallow depth. The frame rate will also go down as it takes longer for deeper sound waves to return back to the probe. And so, it's intuitive that at a large depth, all structures will look smaller. But if we want to focus on things, especially if they're closer to the probe, then decreasing the depth makes sense. The sound waves don't have to travel as deep for us to generate our image. The image will improve in terms of frame rate and spatial resolution. And that can be very important. For example, when calculating a Simpson's biplane, often we'll decrease the depth to cut off the atria because we don't need the atria in full for the Simpson's biplane. And in doing so, we'll actually improve the frame rate and allow us to take a better Simpsons, for example, as shown in the image on the right screen. Where depth is important is obviously looking for deeper structures. And so generally studies start with a deep peristernal long axis to look for pleural effusions. And that's what's being shown on the image on the left side, where at 12 centimeters of depth, if you just had that image at that depth, you may have not seen this effusion, but at 20 centimeters of depth, by increasing the depth, making the image more deep, we're able to appreciate that there's an effusion there. The next button and the knob we'll look at is zoom. So zoom allows you to zoom onto a structure. For example, the mitral valve, this is an example of that. You have a peristernal long axis view, and then a smaller box for zoom is created over the mitral valve. It's important to know that zooming does not increase your resolution. It just makes the pixels look bigger. It's essentially like you have an image, and if you were to take that on the computer and you were to expand it very wide, it doesn't add pixels by doing that. It just allows you to see things in a bigger way. That can still be very useful for focusing your attention on structures, but it's important to note that it won't actually improve your resolution. So depth will improve your resolution if you decrease your depth for something that is closer to the probe, but zoom will just focus your view on one attention, cut out the other aspects of the image, but will not improve the resolution. Next, we look at sector width. So there are various button knobs along the top part here, and one of them is often the sector width. And so what the sector width does is this will increase or decrease, or like widen or narrow your sector. And this can be very useful. A wider sector will obviously have more data. that can see structures. It may be hard to get things completely in view with such a narrow structure, narrow sector. So then you'll want a wider sector, for example. But keep in mind, a wider sector can also drop the frame rate and can also drop the resolution. Like sound waves have to now be emitted over that wide sector. So if you're able to have a more narrow sector to be able to visualize structures, that will improve your temporal resolution, with the consequence that you're not able to see as many structures because you've narrowed things. But if you're able to focus on a specific structure, and sometimes we do that when assessing the tricuspid valve in the short axis, for example, you'll narrow the sector and then tilt the image towards the tricuspid valve, and that'll let you see the tricuspid valve in more detail while cutting out the other structures that we're less interested in for that specific image. And this also is helpful with color, for example. If you have a huge color box, you're often going to drop your frame rate, but by having a smaller color box, your frame rate will improve because there's just less data to process. So that's something else to keep in mind, and it's a general theme with echo. We're going to talk about compression gain and auto gain. So these are structures here, and most trainees are quite familiar with gain. It adjusts the amplitude of the overall image. It makes the image overall brighter and or darker, whereas compression will adjust the black to white ratio. So gain is something I use quite often, as you know, it makes, as I said, it makes the image overall brighter or darker. The compression can be a bit more challenging to get correct. So I think early on, if you want to adjust your image and make it brighter, certainly adjust the gain, but compression will take some practice to get used to. When you get adept at using both, it can be quite helpful to make your images look very nice. Uh, this is another example of compression here. You can see that you have the image on the left that they've started with, and then by adjusting the compression, you can get an image like they have on top, where everything looks, the black parts, so within the cavity, look very black, and the myocardium looks very bright and white. But again, by adjusting the compression, you can make everything look more gray. So that's an example of compression. It makes things look more distinct in terms of the black looking more black and the white looking more white. This is an example of 2D gain. By decreasing the gain, you've made the image, which looked very bright on the left-hand side in the left top corner, look more black, look less bright, more dark overall by decreasing the gain. And you can also do this for Doppler as well. You can, decrease the gain from the Doppler to make the Doppler signal look less bright. Auto gain is a feature. It's used on the GE. It's used on different platforms. And so auto gain is a way that will allow you to it'll constantly be adjusting the gain as it acquires the images. So you don't have to adjust it automatically. iScan is used by the Philips platform, and that is used to again, it's a button that you just press, as opposed to auto gain, which is constantly running. But it's a button that you press, and that will adjust your gain based on how it sees the image. So those can be helpful for adjusting your gains quickly without requiring you to manually optimize it. Then there's the time gain compression, or TGCs. And initially, when I started scanning, I didn't play very much with this, but now that I do more transesophageal echo, I find these extremely helpful. And so what this does is the time gain compensation, TGCs, will adjust the gain at various levels of depth. So moving the slider, and I'm just going to go back a slide here, moving the top sliders will adjust the gain at the top of the imaging screen nearest to the probe, and then moving the sliders towards the left, for example, at the bottom of the platform, will make the image farthest away from the probe, or the deepest portion, it will make that darker. So moving it towards the right will make the image brighter, or that area brighter, and moving it towards the left will make it darker. And that can be very useful to optimize images. Like if you're not interested in structures that are nearest to the probe, or you're more interested, for example, in this case, they want to specifically brighten the inferior wall. They wanted to make that brighter. They increased TGCs in that area to see that area of the myocardium better. So that can be a useful technique to highlight specific areas. Frequency is also something that is used to help optimize your images. This is an example of different frequency settings on the Philips platform. This is an example of P stands for pen, G stands for gen, and R stands for res. There's essentially the big picture things to know is that pen is a low frequency. It's meant to assess deeper tissue and patients who may have difficult images. Gen is usually the default setting. It's a mid-range frequency and is a good all-around frequency to scan patients. And then res describes the highest frequency band for superficial imaging. In generally, I use gen. And so in the last part of the lecture, we're going to talk about beyond 2D echocardiography. We're going to introduce some of these modalities that you may or may not have heard of before that will be helpful for understanding cardiac structures and function. These will include M mode, color Doppler, continuous wave, and pulse wave Doppler, as well as tissue Doppler. So M mode. So M mode is a single scan line is emitted and receives information. So you're tracking the movement of structures along a single line over time. And that's what's being demonstrated in this video here. The imager is lining up the M mode beam and lining up with attention to the anterior mitral valve leaflet. And what you can see, the image that is generated, and I'm just going to wait until it's generated and then I will pause it. They've now activated M mode. And so what you can see here is along the imaging line over time with the cardiac cycle, we see the movement of the anterior mitral valve leaflet very well, in addition to the other structures that are along this line. But the most obvious is the movement of the anterior mitral valve leaflet, and we see a classic E wave and A wave here. So it's very useful for spatial resolution. Of structures over a single line. The resolution is excellent for M mode in this domain, but the images need to be put into context. And so they often have this scout window up here that will show you where that line is being lined up against to help with interpretation. There are some standard areas as part of the echo exam where you would do an M mode, and we will practice some of this. For example, along the aortic valve, see the aortic valve opening, along the peristernal long axis mitral valve, see the anterior mitral valve leaflet opening. In the mid-ventricle, it gives a sense of left ventricular systolic function. The RV annulus for something called TAPSE. And then the IVC assessment are also areas where M mode is very helpful. In each of these areas that we routinely interrogate, there are nuances for pathology as well. This is an example of M mode through the aortic valve, and it shows the aortic valve opening here in systole. And so we're able to see the aortic valve opens quite well there. This is an example of M mode over the anterior mitral valve leaflet. And again, we see the anterior leaflet opening with the in diastole with an E wave and an A wave. This is over the mid-ventricle, as I was saying, and we get a sense of left ventricular systolic function. Other helpful information we may gather is signs of ventricular interdependence, or how the left ventricle and right ventricle are filling over time. Commonly, that's a way we use this, but that's something that's a bit more advanced and you'll learn about over time. Or RV diastolic collapse can be helpful to see here as well with the M mode, because we're able to time it by looking at the RV over the various cardiac cycles. This is an example of TAPSE. So this is the tricuspid annular plane systolic excursion. So this is movement of the tricuspid annular plane during systole, and it's a marker of RV function. And so the M mode line is lined up along the tricuspid annulus in the apical four-chamber view. This is an example of M mode assessing the IVC. And so the IVC can be used to estimate the right atrial pressure. And in this case, the M mode is done over time. The patient is asked to take a sniff in, and we assess the size of the IVC and the collapsibility. And this can be a very useful way of documenting that. And in this case, we see that the IVC is dilated as 2.26 centimeters, 2.3 centimeters. So it's dilated, it's over 2.1. And the collapsibility is less than 50%. When collapsed, it measures 1.54 or 1.5. So collapsibility is less than 50%. So this would be consistent with a right atrial pressure of 15 millimeters mercury. Color Doppler is another common technique we use with 2D echocardiography, and this allows us to visualize blood flow through changes in the ultrasonograph signal due to movement of red blood cells relative to the transducer by assigning a color to the direction of flow. As blood moves towards the probe, the convention is that the flow will be red in color. As blood moves away from the probe, the convention is that the flow will be away from the probe. The velocity in which you alias has a limit, and above that limit, then you start to get turbulent flow, and then the color starts to alias, and we'll show some examples of that. And that velocity can be adjusted and can be dropped for assessing slower flow structures, for example, an atrial septal defect or PFO. It can be useful to drop the maximum velocity for the color, but in general, we keep the color at the maximum, whatever it is able to get for assessing various structures. And above that maximum, the color will start to alias and you'll see more turbulence. And that'll be signified by a change in color to something that's more yellow. So these are examples of patients. This is an apical 3-chamber view on the left-hand side that shows a patient who has mitral regurgitation. You see just before we even talk about the MR jet, you see that you have a red puff up this way. That's diastolic filling, and then the blood curls around and in systole becomes blue and goes down towards the LVOT and the aorta. So again, red towards the probe, blue away from the probe. So that's the diastolic filling and emptying of this left ventricle. Without commenting on the poor left ventricular systolic function, one thing we do notice is the mitral valve leaflets are apically tented, and there's this jet of mitral regurgitation. This jet is much higher in velocity than the inflow view, which is red. It's in the direction of the blue jet, but it starts to alias because it's such high velocity that becomes yellow, and that's why you see this jet of mitral regurgitation here. On the right-hand side of the screen, you see an apical 5-chamber view. This is where tilting has been applied to the apical 4-chamber view to open up the LVOT, and we see there's as blood flows through the LVOT, which starts to narrow, we see a little bit of starts off blue and then it becomes yellow, so it starts to alias as you have some flow through the LVOT, and that can still be normal. And then there's a bit of regurgitation. You appreciate that there's this red jet here of aortic regurgitation that's going towards the probe here. So there's a small bit of aortic regurgitation here. And these are wake color can be very useful for assessing the structure and function of valves. So if flow is perpendicular to the transducer, it's important to note it's not going to show the color well. You're really going to see color well when you're parallel. So for example, this is a suprasternal view, and it's looking at a patient's aortic arch and descending aorta. And you can appreciate with the descending aorta, it's nice blue away from the probe. There's a little bit of color aliasing here, but the horizontal color flow, especially in these branches of the aorta here, we don't see the horizontal flow as it becomes perpendicular away from the probe. So just be aware of that. The color works very well when it's parallel, but the more it's angulated, especially when it becomes perpendicular from the probe, the color may not be seen well. Next, we're going to talk about pulse wave and continuous wave, or PW and CW. These are common Doppler techniques that you will be using to interrogate cardiac structures. In generic terms, pulse wave sends a Doppler signal to one specific point, and then it analyzes from that specific point. So that's what I like to think of with pulse wave is it examines flow at one single point. That's opposed to continuous wave Doppler, which sends signals continuously along one line towards and receives signals along that line continuously. So PW examines flow at one point, CW examines flow everywhere along that line. And that's the key difference between these two different modalities, and they're useful for assessing different aspects of cardiac structure and function. So PW, as I mentioned, assesses blood flow at a point. It's conventionally noted by a double hash point marks, which you don't see well in this image, but we'll see better in other images here. Like with color Doppler, blood flow ideally needs to be parallel, or else the flow and the velocities will be underestimated. And this is an example of a PW in the LVOT. This measures flow in the LVOT and can be useful for calculating the patient's stroke volume, which is then useful for a variety of calculations. This is an example of a PW at the mitral valve inflow level. And so we put the PW point at the mitral valve leaflet tips, and it measures the inflow into the left ventricle, can be useful for measuring the ENA waves, calculating the deceleration slope for other sorts of calculations. So this is an example of a PW. You can adjust the scale and the baseline for PW to optimize your images. So you can see the image on the left, the scale is not optimized. So this is an example of a PW in the LVOT. And because the scale is not large enough, the peak is being cut off. So what they do in the next image, the image on the right, they've increased the scale to go up to 120 as opposed to a scale maximum of just 80 centimeters per second. And this will allow us to see the full profile to take the proper measurement. The sonographers can help you with adjusting these until you get more familiar with these knobs. CW again measures everything along that line. Again, parallel to flow is better. And it's very useful for seeing the maximum flow along that point in the line. So for example, if you want to assess the aortic valve gradient, if you CW right through that aortic valve in the area of flow acceleration and narrowing, you'll be able to be confident that you've captured the gradient. In general, the convention is that CW is noted by a single hash mark, but it could be a diamond or a circle depending on the manufacturer. So you're going to line up the beam to the area of maximum flow. And so, for example, the regurgitation jet or flow acceleration in the LVOT or aorta, depending on what you're interrogating. If the beam's not lined up properly, you're going to underestimate the gradients. Sometimes, as shown in the figure A on the bottom left-hand side of the screen, you might see this double profile when assessing a patient with aortic stenosis. By putting the CW through the LVOT in the aortic valve, you get one profile that's flow in the LVOT, and that's the lower velocity up to 1 meter per second, darker gray profile, and then the lighter gray profile shows the flow through the aortic valve, which is higher velocity in the setting of aortic stenosis. So sometimes you can actually see this double profile velocity. On the image on the bottom right is showing acquisition of a CW through the aortic valve. They've lined it up the CW. You then take the CW, you freeze, and then you would save that measurement. You would save that screen for measurement. So these are some examples of CW profiles. This is an example of aortic valve outflow CW, and you can notice the flow through the aortic valve here by capture with the CW. The pulmonic valve CW will have a very similar profile. Right after the QRS, the ventricle contracts, and then you see ejection through the aortic valve in the image on the left, and ejection through the pulmonic valve on the image on the right. Just notice the pattern that the profiles look similar, and this makes sense because you're going from the ventricle through a VA valve into an artery. So that's why these profiles look similar, because they're analogous, just different sides of the heart. This is an example of a patient with severe aortic stenosis on the right-hand side of the screen. So on the left-hand side of the screen, you have a patient with no aortic stenosis. The Vmax is calculated there at 1.4 meters per second. But then on the right-hand side of the screen, you see a patient with a severe aortic stenosis. The Vmax is over 4 meters per second here. So very, very big differences. Aortic regurgitation is something that can also be assessed with CW, so we can see it with color, and that's what's shown on the right-hand side of the screen. You see in the 5-chamber view, there's this regurgitant jet in diastole, and then we can further assess that by lining up a CW beam as best we can through that regurgitant jet and measuring the profile of the aortic regurgitation. You'll note that the aortic regurgitation profile has this distinct shape where it rapidly rises, slowly decreases, and then flow stops as the aortic valve opens to eject blood out in systole. And you'll notice this profile exists in diastole. And you'll notice also that it is above the baseline. And the reason that it's above the baseline is that it is regurgitant blood that is going towards the probe. This signal is going towards the probe, so it is above the baseline, as opposed to the aortic ejection profile, which is away from the probe and is therefore below the baseline. So just note that as well. Very interesting and similar to the aortic, outflow profiles from the aortic valve and the pulmonic valve. The regurgitation profiles look very similar as well. And again, this just shows the analogy where you're having regurgitant blood from a artery, the pulmonic artery, into the RV through the pulmonic valve, or the aorta into the LV through the aortic valve. And the Doppler profiles look very similar as well. Mitral valve inflow is shown here. This is an example of a CW through the mitral valve, and this is measuring the flow through that through that jet. And so in this case, we have a patient with mitral stenosis. You can see that there's flow acceleration through from the mitral inflow. We see kind of this high velocity color, and when we line up the CW beam against this jet, we're able to create this CW profile that can then be used to measure the gradients. So you wouldn't measure gradients with a PW because we're not sure if we're hitting it at exactly the highest velocity spot, but by using a PW and by taking the flow all along that line, as long as we've lined it up properly, we can be quite comfortable that we're getting an accurate assessment of the impairment of flow from this patient's mitral stenosis, and therefore can accurately calculate a gradient. And so that's an example. And again, keep in mind that the mitral inflow is towards the probe. So this inflow profile with the ENA is, above the baseline. Regurgitation is below the baseline. So this is an example of a regurgitant profile. So this is mitral regurgitation. What you see here on the color is you see the regurgitant jet going from the left ventricle to the left atrium. And then by lining up the CW beam against this jet, we're able to create this Doppler profile. And this Doppler profile can be useful for assessing the severity of the mitral regurgitation, various characteristics of it, such as the density of the profile, as well as quantificative measures can be used to assess severity. This is an example of patients with differing degrees of mitral regurgitation. On the left-hand side of the screen, they have trace MR, and you can see there's just a really faint profile there, but you don't really see it well. In the middle of the screen, you see the patient with mild mitral regurgitation. And again, there's a more full profile than with the trace MR, but it still looks quite faint, as opposed to a patient with moderate to severe MR has a much more dense and full profile. And so depending on the degree of regurgitation and volume of flow and degree of flow with the regurgitation, the profile will look more full. And now tricuspid regurgitation will look very similar. So it has a very similar profile. Just after the QRS, you get the regurgitant flow, and it makes sense, again, because you're going from the ventricle to the atria. In this case, with TR from the right ventricle, blood regurgitates into the left atrium. For MR, blood goes from the left ventricle to the left atrium, but you have an analogous profile in terms of the Doppler signal, and those are patterns that you're going to notice. Again, it's below the baseline because blood is flowing away from the probe in this situation. And again, the density can be useful for helping to determine the degree of severity as shown here. The middle says trace to mild TR, and the profile is not very full, as opposed to a patient with severe TR that has a much more full profile. And then the And again, with no TR, you may not see any profile at all. So putting it all together, when assessing a valve, you're first going to look at your 2D. You're going to get a sense of the structure, the opening of the valve, the leaflets look thickened, etc. And then color is very useful to see flow in and around the valve. And then the CW plus minus PW are going to be useful for hemodynamic assessment of regurgitation or stenosis, for example. Tissue Doppler is a technique that assesses myocardial tissue motion. The velocity compared to blood is much lower, so you'll notice that the velocity profile is much lower. It provides information on tissue contraction and relaxation, and it's useful in a couple ways. The first is in diastolic function, where we measure something called the E prime velocities, and this shows how compliant the ventricle is to the early phase of diastole. Whereas if the E prime is very high, it means the ventricle is able to relax quite well. If the E prime is low, it means the ventricle is not able to relax well. And so these are findings of diastolic dysfunction, for example. And of course, there are caveats that you will learn along your echo training, but we're just keeping things simple for today. Right ventricular systolic function can also be measured with tissue Doppler. We measure this thing called the RVS prime, and this shows how the RV contracts in systole. And so the higher it is generally means that the RV contracts better. This is an example of a tissue Doppler. You'll notice on the top scout image, it's assigned everywhere along the sector to be blue or red. The velocities are much lower compared to other types of Doppler. So in this case, things are gated around 11 centimeters per second. And we're able, with the use of PW, able to estimate the tissue Doppler here and create this sort of profile of which the E prime velocities can be useful for calculating factors of diastology, for example. So there are many areas we can't cover today. And keep in mind that this lecture is a companion to the in-person Echo Bootcamp run at the University of Toronto. And so the goals and the objectives of this lecture here today and the companion lecture on the YouTube channel and the Echo Bootcamp are really just to provide an introduction to echocardiography. We're not going to, be able to teach you a full echo protocol during our Echo Bootcamp, and that's not our goal. But our goal is that by the end of your first echo block, you should be able to perform a full study, and we're going to introduce the aspects of that study to you today, get your hand on the probe, and will hopefully help you feel more comfortable in the transition to cardiology residency. There are various, protocols that have been suggested by labs in terms of focusing. How much do you focus on during your weeks? And this is an example of a sample schedule that is, suggested by some labs in terms of how to organize your training at the start of cardiology residency for your first block of echocardiography. Measurements will not be able to be covered in detail. We're going to introduce some measurements as part of the in-person Echo Bootcamp. Certainly by the end of by your second block of echo, I think you should be doing all your measurements. So I would work to that as a goal, and even on your first block if you're able to. But if you're spending your first block really, working on acquiring images, that's quite okay too. There are various resources that are helpful. Certainly our SMH Echo YouTube channel has a lot of useful videos, including the section and the playlist for newcomers to Echo has a lot of useful videos for how to get started and is recommended for your first and subsequent blocks of echocardiography to learn the various topics you'll need to know. There's also various guidelines in addition to the 2019 guidelines that Dr. Frankfurter reviewed. The 2015 guidelines are also very helpful, and a link is provided here. Reporting, calculations, quantification is going to take time. It requires you to perform and review hundreds of scans. By your third block of echo, I believe you should be reporting the scans that you've acquired. So that's how I generally recommend structuring things, but you're going to find your own way depending on where you train and who trains you. The MD Math website, which I'll show on the next slide, is a very helpful resource, and so we do want to mention that as well. It has tons of calculators for quantification, and I have that open constantly as I read echo. Try to think of, learning echocardiography as an onion, and essentially the boot camp that we introduce will be one layer to that, and you will layer things on over time as you scan more patients, report more studies, and read more studies over time. This is an example of one of the calculators at the MD Math website for the continuity equation, for example, that can be used readily. They have a lot of other useful calculators. The PISA calculator is one that I have constantly open when I'm reporting. And then MD Logbook is a procedural logbook that has been designed for use across Canada. And it's specifically built for cardiologists that allows for logging of procedures. And it's something that we've recommended you can use, for example, to log the echoes that you perform and interpret. With that, I'd like to thank you for your attention to this lecture. Again, for the residents who are listening to this lecture, look forward to meeting you in the boot camp. And my hope is that this lecture can be used in future years and perhaps even at a few other sites across Canada for an echocardiography boot camp. Thank you very much for your attention.